Good day, everybody, and thank you for joining us. My name is Melissa Begg, and I have the great honor of serving as Dean of the Columbia School of Social Work. It's a great pleasure to welcome you and to welcome our outstanding panelists for a really special event centered on a newly published review article in the Lancet HIV entitled Intertwined Epidemics: Progress, Gaps, and Opportunities to Address Intimate Partner Violence and HIV Among Key Populations of Women. This new review highlights that mainstream efforts to prevent intimate partner violence have focused on broad populations of women, too often ignoring marginalized women who experience the highest rates of both violence and HIV. These include transgender women, female sex workers, women who inject drugs, and young girls and adolescents. The fact is that the chance of contracting HIV is higher when there is intimate partner violence, so ignoring this key factor can impede prevention, diagnosis, treatment, and care. Addressing intimate partner violence, therefore, is vital to ending the HIV epidemic. Now, please let me take a moment to introduce our wonderful moderator for this highly anticipated event, Dr. Nabila El-Bassel. Dr. El-Bassel is the Wilma and Albert Musher Professor of Social Work, as well as a university professor, the highest academic honor that can be bestowed on Columbia University faculty, and with good reason. In addition to leading the Healing Communities Study, she directs or co-directs major centers, including the Social Intervention Group, the Global Health Research Center of Central Asia, and the newly established interdisciplinary university-wide center called CHOSEN, the Center for Healing of Opioid and Other Substance Use Disorders, enhancing intervention development and implementation. As all of this attests, Professor El-Bassel's career in social work and public health transcends disciplines. She is one of the world's leading experts in intervention science. She has published extensively on HIV behavioral prevention science, substance use, gender-based violence, and complex cross-disciplinary interventions. She is a remarkably productive researcher, a highly regarded scholar, and a gifted mentor. She serves on Harvard's Scientific Advisory Board on Migration and Health and is a member of Columbia's Provost Advisory Council for the Enhancement of Faculty Diversity. And last year, she received the university's Faculty Mentoring Award. I'm proud to call her my colleague. Now, I know we want to get underway with this exciting and important conversation, but before turning it over to Dr. El-Bassel, I want to take a moment to recognize a deep loss for our community. Yesterday, we learned of the passing of Dr. Cathy Boudin, a remarkable member of the CSSW faculty who co-founded and co-led the Center for Justice. I know Dr. El-Bassel will share a few words, but right now, I'd like to invite all of us to share in a moment of silence in Dr. Boudin's honor. Thank you, everyone. And Dr. El-Bassel, it's my pleasure to hand the mic to you.
Thank you very much, Dean Begg, for your introduction, and thank you very much for all your support for this roundtable discussion. But yes, before we begin the event, I have to say I'm really very sad, and I would like to take this moment to honor our dear friend and colleague, Dr. Cathy Boudin, who passed away yesterday. Cathy was a pioneer in introducing HIV prevention to women in prison when she was in prison. Cathy also led the peer-driven Coming Home HIV Continuum of Care services, which was the first of its kind in New York City. Dr. Boudin was the co-founder of the Columbia Center for Justice. She founded the Criminal Justice Initiative at the School of Social Work, and also she has many, many accomplishments that I even cannot begin to cover. But I would like to say that Cathy made a huge impact on the curriculum of criminal justice issues at the School of Social Work, but also at Columbia University. She taught courses on criminal justice at the school and the university, and in fact, she transformed our curriculum in terms of criminal justice at the school and the university too. She trained many of us and inspired many students and faculty. Really, she's an incredible person. Her incredible work, leadership, and legacy will continue to inspire us in so many ways. We will miss her dearly, but we know her spirit is here with us at this event. Now we are going to move to our event. We have really an exciting program tonight for you. This event brings together world experts in the areas of partner abuse and HIV. These experts that you hear from today will share findings and recommendations from our commissioned paper that was published as Dean Bag said last April in Lancet HIV about women who use drugs, women who engage in sex work, transgender women and girls. The commission paper, as you'll hear very soon, will discuss also a call to action to improve and promote research services and policies that address the link between partner abuse and HIV among these key populations of women. We had three major reasons that led us to write this Lancet HIV paper. The first reason is you all may know a number of studies show that the prevalence of intimate partner violence among key affected populations of women is 2 to 3 times higher than the rate of IPV among women in the general population. Second reason is a number of studies show that experiencing partner violence significantly increases the risk of HIV infection. And also we know that IPV acts as a barrier to HIV prevention and HIV testing. And we know from our work at the Social Intervention Group and other research and found that experiencing partner violence often leads to a lower adherence to antiretroviral therapy, also leads to low retention in HIV care among key populations of women. And the last reason that led us to put this commission paper together is that in many parts of the world, the prevention services and funding to address the combination, the link between partner abuse and HIV is limited and is lacking. So our paper, and you'll see it during our discussion, really call to action that we need to do more and we need to serve these women. We have, again, an amazing group of female scientists today. This group of scientists have dedicated their research to studying and advocating for women who are heavily impacted by both gender-based violence and HIV. I also like to mention in the research, they not only use the women as research participants, but in their methodology, in their work, they involve the women in all the stages of their research, from the conceptualization to implementation and to dissemination of the findings. Before I introduce the speaker and the discussant, let me tell you a little bit about the structure of this roundtable discussion. We will not have formal presentations. Instead, we will be asking the speakers to respond to specific questions. Then we'll have with the speakers around 45 minutes to respond to the questions. And after 45 minutes, we'll get Dr. Sherman to summarize as a discussant what she heard from the speakers. We will have 15 minutes for questions and answers. We received a lot of questions from the audience, and I have to say that we will respond first to the questions that we received, and if we have time, we will respond to the question that we will be getting during the presentations. But also we are going to put the names of the speakers and their contact information that the audience can contact the speakers afterward if we don't respond to their questions. So let me begin by introducing the speakers. So the first person is Dr. Louisa Gilbert, is an associate professor at Columbia University School of Social Work. She has served as co-director of the Social Intervention Group since 1999. For more than 25 years, Dr. Gilbert focused on developing, testing, implementing multi-level intervention that address the syndemic mechanisms linking substance use, gender-based violence, trauma, and HIV in the US, Central Asia, and in India. This research has advanced evidence-based intervention to prevent both gender-based violence and HIV among women who use drugs. Next is Dr. Jamila Stockman. Dr. Stockman is a professor and vice chief of Global and Public Health Division of Infectious Diseases at the Global Public Health, University of California School of Medicine. Dr. Stockman, a trained epidemiologist, conducts research on the intersecting epidemics of gender-based violence, HIV, substance use, and mental health in context of social structural factors affecting marginalized populations. Next is Dr. Victoria Frye. Dr. Frye is a medical professor of community health and social medicine at the City University of New York School of Medicine, where she heads the Laboratory of Urban Community Health. She is cross-trained in social sciences, in epidemiology theory and methods, and her research focuses on designing and testing intervention to reduce HIV, interpersonal violence among population vulnerable to HIV and violence. She has done a lot of work with women who engage in sex work and Black men or African-American, gay, bisexual, and same-gender loving men. Next is Dr. Trena Mukherjee. She's a doctorate candidate in epidemiology at Columbia Mailman School of Public Health. Trena's research examines how gender intersects with substance use, infectious diseases, and criminal justice. Her research focuses on implementation science and other community-engaged research methods to improve the lives of marginalized populations. Next is Dr. Laura Starbird. Dr. Laura Starbird is an assistant professor in the Department of Family and Community Health at the University of Pennsylvania School of Nursing. She brings expertise in post-analysis and implementation science to a program of research focused on organization-level intervention to remove barriers to healthcare for women who use drugs and also associated infectious diseases such as HIV. Next is Dr. Claudia Stoicescu. Dr. Claudia Stoicescu is an associate professor of public health at Monash University in Indonesia, and she is visiting associate research scientist at the Social Intervention at School of Social Work. She has done extensive work in community-engaged health equity research with marginalized women and other populations of people who use drugs and those involved with the criminal justice system. Her current research in Indonesia is rooted in participatory community-based approach to address and reduce health and social issues. Thank you, Claudia. I know it's also 4 o'clock in Indonesia. We appreciate your participation at so early. Thank you. And next is our discussant, Dr. Susan Sherman, is a Bloomberg American Professor of Health in the Department of Health, Behavior and Society at the Johns Hopkins School of Public Health. Her research takes place in domestic and global settings, with the majority of her work on her research conducted in Baltimore. For over than 20 years, her research has examined specific environmental and structural drivers of HIV and overdose among women who sell sex, including the nature and the impact of the occupational risk environment on exotic dancers and the role of the police and criminalization on the health of women who engage in sex work. She contributed to numerous policy-related reports, and now she is also the chair of the board of the National Harm Reduction Coalition and is a member of several city and state harm reduction advisory board. Today, Dr. Sherman will serve as a discussant, so she will be to speak the last person. So thank you all for being here, and thank you for working on the paper, and it was a pleasure for all of us to produce the paper. So I want to start the first question, and I want to give it to Eloisa. Eloisa, in the paper, you talked about, as a group, on the context that link partner abuse and HIV among women who use drugs. And in the paper, you said there are really unique contexts that link these two epidemics. Can you tell us what these contexts are?
Sure, thank you, Nabila. Yes, as our paper highlighted, research over the past 25 years has documented multiple biopsychosocial mechanisms that link IPV to a range of HIV risks and poor HIV outcomes. And these associations are bidirectional and vary by type and severity of IPV. More recent research has really highlighted the role of social determinants of health, like stigma, racism, lack of access to services, homelessness, aggressive policing, and incarceration, and synergistically enhancing and reinforcing these biopsychosocial mechanisms. What I think is really important to keep in mind is that the relationship between IPV and HIV evolves and plays out very differently among different key populations, and that women who, and it depends on their power, positionality, and intersecting identities. So women who identify as sexual minorities and racial ethnic minorities face much more stigma and discrimination and have much tougher time accessing IPV services and police protection. So it's also important to acknowledge that many women who use drugs are also engaged in sex work and are HIV positive and transgender. They're not distinct key populations.
Thank you. Jamila, I know you also study the contacts that link IPV and HIV, and you have written a lot about this topic. I wonder if you have more to add to what Louisa reported.
Sure, thank you, Nabila. In addition to what Louisa mentioned, another key important feature of the biopsychosocial mechanisms linking IPV and HIV among women is the biological pathway. So this pathway is very understudied in the literature. And what we know is that forced or coerced sex by a seropositive partner can result in genital lacerations or injuries, facilitating HIV transmission through a number of different mechanisms, specifically through the subsequent local inflammatory response. And in addition to sexual IPV, other forms of IPV can induce chronic stress, which alters the normal stress response and contributes to chronic inflammation, also contributing to immune dysfunction and an altered vaginal microenvironment. So collectively, all of these pathways increase women's susceptibility to HIV. And what we do not yet know is whether the biological mechanisms are the same for different key populations of women, given some of the unique social determinants of health previously mentioned by Louisa. Nonetheless, the biological pathway, when we think about it, and which we need to study more, particularly related to the female genital tract, is distinct from other populations, such as men who have sex with men, which emphasizes the importance of clinical stabilization focused interventions for women.
Thank you, Jamila. So Louisa and you highlighted the social contact, the structural contact, the interpersonal, and the biological contacts that link IPV and HIV among women who use drugs or sex workers and transgender women and girls. So there are specific contacts that you describe. I wonder, and this is to you, Jamila, can you speak about why it is important to understand the contexts that link IPV and HIV? Why we need to look at the unique contexts?
Sure, thank you, Nabila. Context, specifically sociostructural and community level in nature, what we know is they can vary by different key populations. So we want to think of an example. Among transgender women, the effects of stigma related to gender identities, such as violence, discrimination, and transphobia, contribute to transgender women's vulnerability to HIV. Whereas among transgender women who are also engaged in sex work, the context of discrimination may present itself in the form of forced or coerced sex perpetrated by a client. So understanding the unique context in which IPV and HIV are linked in key populations will facilitate more tailored and, most importantly, cost-effective interventions to achieve maximal reductions in both IPV and HIV.
Absolutely, and we'll come back to the type of interventions that we need that address the unique context. So I'll come back to this question and ask you about unique interventions. But now I want to move to a different question. In the paper, and especially this is for Victoria, in the paper, we mentioned that the scope and prevalence of IPV is not well defined, it's not well measured. There is a lack of a clear definition, which really impact access to treatment and care. Could you speak into this issue? What do you mean by lack of measurement and adequate conceptualization?
Sure. Thank you for the question. I think it's important to note that we have actually made tremendous progress in this regard over the last 20, 30 years. So I don't want anyone to think that we haven't made some progress, but we are still plagued by measurement issues. And I think that, we continue to struggle to collect valid and reliable data on IPV, particularly with representative samples among the most vulnerable subpopulations of women. And these women are the most marginalized and the most stigmatized. So they're often hidden and very hard to reach. Though I do want to note that surveys like the IBBS, the Integrated Biological and Behavioral Assessments reports, have really made good progress. But a lot of times women who exchange sex for money or other needed resources are not included in these groups, as are transgender women not included. As well, asking some of these women to engage in this research can be very dangerous for them. It can make them much more vulnerable to violence and thus HIV. So it's a big challenge that we continue to grapple with. I think one of the other major challenges is that we often don't focus our research and the measurement at levels that might have the most impact in the long term. And so we sort of focus on levels that are the easiest to access. And by this, I mean that we will measure things at the individual level, and we will design and test interventions at the individual level, or group levels, for example, psychosocial interventions that focus on individual level behavior change, which can help, of course, but that it may not have as much impact as, say, a structural intervention. And so I think that, really what we need is better measurement and analysis of the impact of structural and policy interventions, and to test, or even simulation models that would help us understand how major policy changes or massive shift in social norms, again, for example, around stigmatized behaviors or identities, how that impacts the context and thus the incidence of both IPV and HIV. And we can compare those and determine, again, where we get the most impact in the short and the long term.
Yeah. Trena, you have written about a lack of IPV measurement and a lack of a really consistent definition, which impact access to treatment and care, and also impact science. Do you have more to add to what Victoria said?
Yeah, so just in addition to being able to access these hidden populations, I think it's also important to consider how IPV may present differently in key populations of women. So currently, most IPV research uses these standardized measurements or scales, so like from the WHO or the conflict tactics scale, which have been primarily developed for general populations of women. And so the problem with using this measure among key populations is that it may not adequately measure some of the other forms of IPV that these women may experience. And so just like an example would be like a partner interfering with gender affirming services for transgender women, or a partner coercing a woman into sex work to support drug use. So things like this would not be adequately captured in some of the standardized measures that are currently being used. And then I think the other thing that I just wanted to note is that often with IPV, there's various subtypes of violence. So it can be physical or sexual or psychological or economic, just for example. And so we don't have the best understanding of how these various subtypes of IPV may impact HIV in terms of prevention or even retention and care for those living with HIV.
Thank you. When we go back to Victoria, we know that research has shown that IPV increased during COVID, and most of the papers that were written about increase of IPV during COVID were about women in the general population, less about women who, a key population of women that we are talking about today. Can you comment whether this is true, and what do you know about IPV during COVID?
Absolutely. So, I mean, this sort of loops back to the need for consistent, high quality, systematic data collection with highly vulnerable populations, both in the US and globally, because these groups haven't really been adequately focused on, or for example, for example, adequately oversampled at baseline pre-COVID, it's hard to definitively say that it has increased. However, all the research, or most of the research so far, indicates that IPV has increased. And there are a number of innovative studies that have emerged recently here in the US, for example, that have used social media to document that there has been an increase, as well as some traditional surveys at the state and local level. And so, it's very hard to answer this question, again, because we haven't had, an adequate sort of infusion of resources into this question and into answering this question. But what we know will happen, and we have some indication that it is happening, for example, here in New York City, is that there are synergies where IPV is increasing and the COVID-related lockdowns are impeding service access. It's creating further financial and housing insecurity, as well as a general feeling of disconnection. And that this is going to exacerbate IPV, as well as potentially increase drug use, reduce feelings of control over sexual engagement and encounters. And we're seeing some increases in STIs among some subgroups of women here in New York City, for example. And all of these can combine to make women in these more vulnerable groups even more vulnerable. And this is just a storm of negative forces that we absolutely have to begin focusing on, both in the research and in the services, and directing more of our attention to.
Would you agree that most of the reports on increased IPV during COVID were on the general population and less on key populations of women who use drugs or women who engage in sex work?
Yep. And this is when you look at the literature, that's what you see. And again, we sort of know the reasons for it, but it's that lack of adequate attention at baseline that if you don't pay adequate attention pre-disaster, and these disasters have been empirically demonstrated to increase IPV, whether it's a quote unquote natural disaster, a political disaster, forced migration, et cetera. So we know that it's going to happen, and yet we consistently don't sort of prepare the groundwork to document it and respond appropriately.
Absolutely. Trena, do you have to add to this? Because you have been talking about how IPV increased during COVID among vulnerable populations of women.
Yeah, so also because of COVID lockdowns, access to healthcare, so including HIV testing to diagnose new cases or harm reduction for HIV prevention, as well as access to treatment, were really reduced. And so at the same time, violence has also increased, and access to domestic violence shelters or other resources for IPV have been also reduced, as well as post-violence care. And so this can all come together to really result in even higher risk for HIV.
Thank you. I want to move to talk about interventions now. We talked about the context, we talked about measurement. I want to move to talk about interventions. I know, Claudia, you have invested so many years and publications around successful intervention. And I wonder if you could share with us about a successful intervention that address IPV and HIV in a global context. I know your work has been global, and I wonder if you could share with us what these interventions look like.
So we can see a few common elements in the 25 promising combination interventions that we identified in the paper, which co-target both intimate partner violence and HIV risk. So these include elements like improving communication, trust, and security between partners in intimate relationships, improving access to and uptake of existing services, services for preventing HIV and violence and addressing it when it happens, by enhancing referral systems and peer-to-peer outreach. And at the same time, we've seen that it's very important to recognize the underlying trauma that many women face, as well as the mutually reinforcing and cyclical relationships between drug use, alcohol use, trauma, violence, and HIV. Unfortunately, very few of these interventions address the broader socioeconomic and structural conditions, as some of the previous speakers mentioned. These conditions that actually perpetuate harmful gender norms and promote tolerance of violence against women in many contexts around the world. So strategies that show promise in this regard include providing economic support and social empowerment to women through income generation and microfinance schemes, for example, in South Africa, community mobilization and empowerment programs in India, as we've seen with sex workers there. But a key barrier to the success and scale up of many of these promising interventions and to them actually reaching the most at-risk and marginalized women remains the continuing criminalization of sex work and drug use.
I know that Louisa and Jamila, you also have been working on creating evidence-based interventions, and you yourself created successful interventions to address IPV and HIV. What would you add to what Claudia reported to us?
So Claudia's right in that, there are definitely common elements across some of these combination interventions. And, what I've observed is that at the individual level, these interventions have shown improvements in terms of areas around safer sex negotiations, safety planning, referral and linkage to IPV, not only IPV services, but HIV services as well. And collectively, these have promoted reductions in IPV and HIV. In addition, although there has not been much targeted in terms of the socio-structural level types of interventions, we do know that school-based and community-based interventions have been implemented, and they have been successful at promoting changing social norms, increasing support networks, and uplifting community mobilization efforts in general, which also has had an impact on reductions in IPV and HIV.
Mm-hmm. Yeah, no, I think Victoria and Jamila covered so much of it, but I do want to just point out a couple of gaps where I think we're at right now. One is, while we do have a robust portfolio of individual level and group level interventions, for most key populations, our review showed no evidence-based interventions for transgender women. And this is a huge gap in the field that really needs to be addressed. And I hope we have time to discuss this on the panel. I would also say that a lot of these interventions are still on academic shelves. We really need to get them into practice, and there's a huge need for implementation research that's community-driven, led by women from these key stakeholders, to really address all the system level and organizational level barriers to scaling up these interventions in practice. And there's also a huge need for policy and advocacy work to mobilize communities and hold all levels of government accountable to provide a full array of IPV services to key populations.
I know, Claudia, you have been writing a lot about these issues, and your global work, you work with the United Nations, WHO, you're publishing about these issues. You also, as you mentioned, there are 25 evidence-based interventions that address IPV and HIV. They're not getting to the women themselves. And I wonder, what do you think prevents this intervention from getting to the women? And you have written about this issue. What needs to be done? I mean, there are not many, 25 is not a lot. And so, but as Louisa said, they're sitting on the shelves and not getting to the women. What needs to be done?
You're right, Nabila. So as I mentioned earlier, and as the previous speakers also pointed out, many of these interventions that dually address HIV and intimate partner violence, the few that are tested with marginalized women remain in the research sphere and haven't been successfully integrated into existing services. And this is a huge gap. And part of the reason for this is really a gap and lack of focus and resources on implementation research to help us understand how to work with dual focused interventions in real world conditions and very different geographical contexts. Another reason why women aren't accessing these programs where they might exist, even in pilot form, is the persistent stigma and discrimination that that women from marginalized groups continue to face from service providers. One example that I can see here in Indonesia, but I know is relevant globally as well across many settings, is that many violence prevention services, domestic violence shelters, continue to refuse to admit women who are actively using drugs. And being denied access to a safe space can really be a matter of life and death in these situations, and almost always places these women at even greater risk. And for women who use drugs, for sex workers, the added criminalization of these behaviors and the lack of availability of gender-sensitive harm reduction services in many settings further isolate them from accessing these health and social support services, and it again add to the cycle of risk and violence continuing.
Absolutely. You mentioned that a number of domestic violence in a global context don't even accept women with history of drug use. And I want to ask Louisa. Louisa has written about it, has in fact fought against a lot of barriers. In New York City, we're facing this, where women who use drugs cannot access domestic violence shelter.
Thank you, Nabila. We have one shelter program in New York City that will accept women who are actively using drugs. And it's not acceptable. It is not acceptable. There's such a huge need. And it's really discrimination and stigma. And if you think about the way HIV services work, they are really resource allocated to key population. IPV services remain across the world, including the US, targeting mainstream populations of women that aren't really focused on addressing the huge rates of violence among these key populations. You wouldn't run an HIV program like that. Why are you letting IPV services being allocated this way?
Absolutely.
I just wanted to jump in and reinforce this, that these budgets and the way we allocate resources reflect our moral thoughts and beliefs about all of this, and that these are moral documents and choices. There's a lack of political will, and it's reflected in research funding, and it's reflected in the distribution of resources within the states, both broadly, globally, and here in the United States. And it's absolutely connected to the stigma and discrimination that these groups of women face. And it's extraordinarily violent, both at the policy level and interpersonally.
Absolutely. Yeah, we have been advocating for better access to domestic shelters for women and who use drugs since the last 20 years. We also been advocating for funding to address this issue for women who use drugs and to access treatment, and it's working very slowly. So a lot of work needs to be done. And I fully agree with you, Victoria, and its policies are impacting access to treatment and care that we need to fight hard. And now we can spend the whole hour talking about these issues and give more examples. So if we have time, we'll come back to all these issues because they're really, really important issues, how you get treatment and services to women, how you influence policies. And hopefully we'll be able to get maybe back to these issues. But I want to move to now to a different question, and I want to ask Laura. Laura, in the paper, we talked about gap exists in cost and cost effectiveness research. Can you tell us how we define cost effectiveness and what is missing from the research and why it's missing?
Yeah, absolutely. Thank you, Nabila. And, this is just so poignant when we build on what policymakers really need in order to to implement different programs and what they need to be able to make decisions. And so, you know, as others have mentioned tonight, we are really in a need for community-driven implementation science research so that we can scale up these interventions in lower resource agencies and communities. And I think that one key component of understanding how feasible it is to scale up and integrate some of these combination interventions into routine practice and policy is having the data on the economic implications of doing so. You know, not only from a practical perspective, of course, of what resources does an agency need to actually roll out a new program, but also so that we can make the case to policymakers that this program is a good investment for society or for the healthcare system because of the outcome it achieves. And that's so important for these groups of women who, as Victoria pointed out, you know, are usually not prioritized in policy. And so if we can really make the case using some of this economic research, which unfortunately is their language, you know, in many cases, then we may be able to improve how we implement these interventions.
Can you give us an example of how this type of research cost and cost effectiveness really, and like a model of how it influenced the science of intervention research for women who use drugs or sex workers?
Absolutely. Right. So new interventions, such as those that we outlined in our review, often add services, which of course, you know, sometimes result in higher costs compared to the standard of care that we're currently delivering. But it doesn't necessarily mean that implementing that intervention will be a burden to the agency that implements it, or, you know, to whatever organization or government decides to roll it out. So it's really important to know then what the cost is, but also whether that cost is in line with how we value the outcome the intervention achieves. So it's a lot about our values, right, as a society. And if we're actually getting more value for the added cost compared to what we're doing already, you know, so it's that bang for your buck. What is that bang for your buck that you're getting? So for example, in our paper, we described a community mobilization intervention and peer outreach intervention that did demonstrate significant decreases in IPV and HIV incidence in India. But of course, that program, you know, also requires additional resources. So a cost effectiveness analysis alongside that trial showed that the intervention actually only cost $16 per disability adjusted life year averted, which ends up being well below what the World Health Organization says is an acceptable amount for this significant improvement in health. You know, and so if we're not analyzing the economic cost of these interventions within the context of its effectiveness or benefit, then stakeholders can simply look at the added cost and just reject implementing something new. But we know that this is so important for these key populations of women, again, who are typically not the recipients of expensive new initiatives, you know, and your fancy new initiatives, they get all this press. So it's really important that we're actually looking at this and the cost and the effectiveness so that we can make that case to people that these are interventions that are really benefiting what's going on in society.
Laura, in the review, in the paper, you found very, very few, I don't remember how many studies that looked at cost and cost effectiveness. And
Yeah.
sure most of them also in a global context more than the US context. So can you tell us what these interventions were and from which countries that they looked at cost and effectiveness?
Yes, so we only in our review found one study among key populations. I'll reiterate, you know, there actually are several studies that do look at cost and cost effectiveness among general populations, looking at decreasing the incidence of IPV and HIV, but we actually only identified one of the interventions that we reviewed that also did a cost effectiveness analysis. And that was that community mobilization intervention in India. And so, you know, it's tricky, and we do see that there is a push now to publish more of these studies. And we were able to find in several of the published protocols, you know, of these studies that they plan to do cost effectiveness analyses, but we're not seeing those published in the literature yet.
Yeah, an area of research that really needs more attention.
Mm-hmm.
I want to go back to Claudia and then Laura to you. What do you think the type of data would makers need to address this research gap? What we should be giving them to really make a difference? Because policymakers looking for data.
Yeah, I think we've touched on it earlier in the panel as well. But in the first instance, we need to have representative and gender disaggregated estimates of different forms of gender-based violence, including some of the other types, the less commonly measured types of violence, economic violence, and violence perpetrated by non-intimate partners for key populations. And in terms of intervention research, Laura just mentioned also the huge need to do better at integrating health economics research, cost effectiveness, and cost benefit studies into intimate partner violence and HIV implementation research. And I think another key point that I want to reiterate that has already been mentioned several times is, again, if we want to achieve population level impact, we have to invest in those multi-level and combination approaches that target the harmful risk environments and the kind of structurally violent socioeconomic conditions that sex workers, women who use drugs, transgender women, and other women from key populations exist, live in, and use drugs in. And finally, I would say that we don't have sufficient understanding of what we might already be implementing that doesn't work, partly because of publication bias. Studies that don't have positive findings often tend not to get published. So this might be an interesting area to explore further. What are we doing that doesn't work?
Can you say more about this issue? I fully agree with you. So how do we do it? How do we look at programs that don't work or we work, but we don't publish them? What do we do? What do you think is the best approach to move forward this kind of issue?
Well, I think we need to start with a better understanding the existing contexts, where we are implementing interventions. So with the example that came up earlier of domestic violence shelters, these are existing interventions that are being implemented. Let's understand what is happening in those contexts that is preventing women from key populations from accessing them. Start evaluating those existing interventions and seeing where there are gaps. I would start there.
Yeah. Laura, do you want to add?
Sure. I'll just say I completely agree with Claudia about the data that are needed. And I would just add that, in terms of implementation outcomes that we really need to be looking at are those very process-oriented outcomes, such as, are these interventions acceptable to the women that are receiving them and the organizations involved in implementing them? What are the resources involved in doing this intervention, and what is needed in order to make it sustainable in the communities that we're implementing them in?
Mm-hmm. This question is for any one of you. I'm aware that when you do your work, your research, you involve the women not as participants, but you involve them in all the stages of the research, from the beginning till the end, from conceptualizing the research questions to implementing, disseminating the findings. Could you, any one of you can respond to this question, tell us how do you do it? Anyone would like to take this question?
I can jump in and really just it's about the principle of nothing about us without us. I think we need to recognize that people for whom we are testing interventions or changing policies need to be involved in all aspects of that work, and that means evaluating these populations not just as data collectors in research, but also providing opportunities for leadership positions, valuing transgender researchers, and really ensuring that budgets are also a question that that women from key populations have a say in, that the community organizations and community stakeholders we're partnering with also get a say about how we spend research funding.
Anyone wants to add? Victoria,
I'll say something.
Jamila.
So in addition to involving, our participants and women with these lived experiences at different portions of the whole research phase, doing it in a trauma-informed manner is really, really critical. So we know that participants, we spend a lot of time ensuring that, how we collect data, how we recruit participants are, we're following trauma-informed principles. But I think we really need to be mindful on the staffing side of things, that we need to ensure that we are also applying those trauma-informed principles to our staff and to women who are involved in the conceptualization to implementation to dissemination of findings.
And this is an approach that you have used and you have published about it successfully, where you provide this kind of support to your research team, which is really very important. And I really appreciate all your publication around it and how you inform the field about this issue.
Thanks, Nabila.
No, you really have, and it's that vicarious trauma that women with lived experience re-experience when they're working with a population is a huge issue. But I do also want to say, I think while we have, really try to engage community in all phases of developing, designing, and evaluating these interventions and disseminating these interventions, I think we need to do much better. I think we need a paradigm shift that really creates a new table where it's not inviting community members to the research table and trying to build capacity and research. It's really letting them lead and stepping back and building capacity to support that, because I don't feel like we're there yet. I feel like there's a lot more way that we need to go as researchers. I personally feel that I would like to see the research move to truly community-driven research, which means, really looking at how decision-making happens to build that women with, who come from these key populations should be leading the design and research, and how do we make that happen? And I think that's the challenge that I feel like we're still very much up against, honestly.
Mm-hmm. Victoria, you want to add?
I'll just add that I think that we can and must do a lot better, but that there's also a role for federal funders of both research and programs. In terms of programs, for example, sexual violence prevention programs, as it sort of trickles down from the CDC to the states to the local community-based organizations, are typically told they have to use 3 or 4 evidence-based interventions that are not appropriate for the diverse populations that they serve. And so, for example, the New York City Alliance Against Sexual Assault was able to develop a really innovative program that was developed by Asian and South Asian youth to meet their needs. But then the process of getting it, having the intervention evaluated, that is then another big cycle to demonstrate that it's evidence-based. And there's just not enough resources to support that. So while the will is there, the ability is there, and it does happen, the resources to actually bring it full circle are not there. And that is a huge problem. Similarly, in research, simply demonstrating that someone who has lived expertise is qualified to be a program director, a project director, or a PI, co-investigator can be challenging. That needs to change.
Yeah.
And I do think that many institutes really there's a lot of folks who are willing to do that, but there is a paradigm shift that's needed, that the expertise is not only contained in the PhD. In fact, it's often very much not, to be sorry to all of us.
That's really a very important topic, and I wish we have time. We can spend the whole presentation or the discussion around this issue. Yeah, we need a paradigm shift about how we do business and how funding are not supporting people with lived experience to be PIs and others. So, Trena, I know you have been talking about these issues. Do you have to add? Do you have to add to what was said before?
I mean, I just kind of want to echo based off what everyone else said, just really involving women in key populations and people with lived experience to do community engaged research. And so potentially using implementation science or community-based participatory science or implementation science or human-centered design to really make sure that interventions are not just top down, but also bottom up.
Absolutely. Laura, do you have anything to add?
I mean, I think I just agree with everybody. And I think it's just, you know, as we think about governments and health systems and organizations and what they need to implement these things, they don't always, you know, necessarily have what's best. And I just agree with everybody. We need to be listening to these populations more.
Okay. I'm going to ask the last question to each panelist to take 1 minute for a final comment or a message to advocate for better research and services for key affected women, and also improving access to care, but improving research. And I want to start with Jamila.
Okay. So, you know, earlier I spoke about context, and, you know, we still have a dearth of observational research studies designed to unpack biological, community, and social structural factors contributing to the mechanisms linking IPV and HIV among key populations. So it's really, really imperative to close these gaps in the knowledge that is still left there to be unpacked, because in order to develop or adapt interventions, we really need to understand the context in which these mechanisms are linked and how they play out in specific key populations. And then that's the only way, again, that I feel we can move towards more efficient and targeted combination interventions that simultaneously promote maximal reductions for IPV and HIV.
Thank you. Claudia?
I'll just pick up on the last bit of the conversation, which was really about nothing about us without us. Just to say that, you know, applying the principle of meaningful involvement in my own research has taken a lot of uncomfortable conversations around power dynamics, around what expertise is and what it means as applied in the research process. And a lot of very difficult decisions around funding. And we just need to keep having those uncomfortable conversations. I'm not there yet. And as research, as a field, I don't think we're there yet. And you know, we need to get out of our comfort zone as researchers, as ethics boards, as funders, and be uncomfortable.
Mm-hmm. Trena?
I think I would just kind of want to advocate for a better measurement of IPV among key populations, just so that, you know, in order to address the problem, we really need a better understanding of the scope of the problem. And so this includes just understanding and considering forms of IPV that are really unique or specific for key populations, attempting to understand how the various subtypes of IPV interact to really contribute to adverse health outcomes, and even potentially harmonizing how IPV is measured or categorized when evaluating intervention outcomes.
Mm-hmm. Laura?
I'll just say, you know, again, that governments and organizations and our healthcare infrastructure in reality has limited resources. And so, you know, we have to work with the fact that any resources that are spent on one program can't be used for another. So this makes it even more crucial that we're able to make the case for these interventions as a worthy investment, because unfortunately, these populations aren't always prioritized or acknowledged. And we can do this by conducting more robust research on their cost effectiveness and on the long-term societal and economic implications of implementing them in real-world settings.
Thank you. Victoria?
I'll just build on what Laura said and sort of note again that the resource distribution, these budgets are moral documents. And indeed, there are some places that are extremely resource limited. And then there are others that are not, where moral decisions are being made and certain subpopulations of women are being left out because of moralizing around their behavior. And that this is something that we absolutely need to examine at every level, and look at the reciprocal relationship between the social norms, stigmatization, funding, and program implementation, and really try to interrupt that cycle, because it feeds into who is a worthwhile victim, who is a worthy woman, and who is not. And that ties to the idea of, what interventions keep getting implemented over and over, and which ones don't get even developed to begin with. And I think we need to dig into that cycle and disrupt it.
Thank you. Louisa?
Yes, hard to add to all of this, but I go back to this idea of the HIV, working in both the HIV and IPV fields. We just see such huge disparities in terms of, in the HIV field, most governments are expected to provide routine annual surveillance on HIV incidence and prevalence, as well as 90-90 targets in terms of indicators towards progress of being tested, linked to treatment, and virally suppressed. Fairly clear targets for all key populations. We don't have that for IPV. We don't even have population-based estimates of different types of IPV and GBV among, key populations, nor do we have anything about their access to key IPV services. And without that data, mainstream IPV services are still going to go on as serving the general population of women and driving resource allocation, where if we really could be able to disaggregate it and show it by key population, like we do for the HIV field, we would be in a very different place in terms of where the resource allocation goes towards these key populations.
Thank you. Looking at the time, we are looking forward to move to Dr. Sherman. First, I want to thank all of you for your commitment to addressing the impact of partner abuse and HIV on the lives of many women, and for your dedication for the research on this topic. And we're hoping that this paper that you put together to advocate for more funding, for more research, and get to the right people to see the severity of the issues, and there's so much to be done in this area. Having said that, now I want to turn the floor to Susan Sherman, our discussant, who will provide a few insights about what she has heard from today's panelists and her own experience in her own research, which I mentioned earlier. She has more than 2 decades of working in this area of violence against women and HIV.
Thanks, Nabila. Today, though, and thank you so much for inviting me. And honestly, it's tremendous. This sounds trite, but it's so not true to hear all of your all's experiences and brilliant and mostly commitment and passion. I'm willing to say stuff that is challenges ourselves as researchers and also challenges to the broader community. It is very rare that people talk about, as you did, Claudia, how hard the work is to engage with community and how it's uncomfortable. And we don't often put ourselves in situations, I think, that are uncomfortable. So I appreciate that. Okay, so in 6 minutes, I am not talking about my own work. I'm going to talk a little bit about what I heard today and things that I thought were really important, and to just hopefully summarize, give somewhat of justice of what you've said, and how you all have done an incredible job bringing together the ways in which violence structures HIV and really vice versa among a diversity of groups of women. As Louisa mentioned, the experiences, such factors of stigma and racism and egregious police practices really are experienced differently across these populations. Yet there are a number of commonalities in these populations, including, it's amazing to me to think that in 2022, we are still talking about these insanely high rates of IPV and HIV among populations who aren't really hidden in lots of places. They're not hidden when they come in the US to our emergency rooms. They just somehow are hidden in policy discussions and program discussions and funding discussions. So it's great that we keep showing up and keep beating the drum that these are populations that are important to be heard from and heard about. But it really is just such a comment about the patriarchy, I think, in the state of the world that we're still talking about this in 2022. But I digress a little bit. One of the reasons why I think that there's such invisibility is the lack of surveillance, not only about IPV, but also these populations. It wasn't until recently in the US context that HIV among sex work has started to be kind of looked at and documented in the National HIV Behavioral Surveillance Study. How is that? They were, sex workers where there was one question, for example, on have you traded sex for money, food, or other services in the past 12 months? That was on the 2 cycles of the 3 cycles of the National HIV Behavioral Surveillance. And there are other, and for sure, I mean, what was just discussed, the fact that there's no documentation of IPV in any country. So it's easy to ignore it and not have an advocacy constituency when things are not documented. But hopefully conversations like today and the really, really well written and the paper that cites so many different studies will help shift this conversation. So there are a few takeaways from today's panel that each of you touched upon. The first, measurement Trena talked about. It's so important. It's great that there are WHO and, the conflict tactic scale is something that's so important that has brought this notion of violence existing in populations really to the foreground. But we need to understand the nuances of how violence presents itself in transgender women or adolescent girls, which allows us to really document the prevalence and also the nature, and ultimately inform relevant intervention policies and programmings, both across populations and in different geographic settings. Also, there was a lot spoken, all of you talked about the need for complex multi-level structural interventions and implementation research. You all touched on some part of each of that across these populations that are duly focused on IPV and HIV. Jamila talked about the fact that while we do still need observational research that articulates the nature of biological and socio-behavioral variables that are relevant in driving HIV and IPV, but we really need to move beyond we know a lot about what drives populations to experiencing these HIV and IPV. We need to move beyond, I liked that whole notion of not having something on the shelves of the academy into implementation contexts. It's amazing that there's still few examples of successful combination interventions that have an impact on IPV and HIV when the drivers are the same: homelessness, violence, poverty, lack of stable food supplies. The list goes on there's so many common drivers, but we don't often measure outcomes. There aren't studies that measures how these various interventions impact both of these outcomes. And it's really important, Claudia talked about this, to focus on the only way that we are going to see long-term changes in interpersonal violence and HIV among the populations talked about today is if we have messy, complex, multi-level interventions. You can't talk about condom negotiation, which is important among street-based sex workers, women that I've worked with a number of years. If their agency is completely eclipsed by the fact that sex work is criminalized. So without thinking about that context, you're kind of blowing money into the wind. I think it's so important. I mean, also other types of intervention research that was discussed today. Laura, it's great. You're kind of the token cost effectiveness person who's always important to be in the room, even though you're the lone voice that does that kind of research. But really putting your money where your mouth is. Sometimes policymakers, it's the only thing that they can't it speaks their language, and they can't avoid looking at how this is so cost effective. And another area of research that's just so important for us all to engage in is that of implementation research, partnering with people that have lived experience, partnering with community-based organizations, putting in grants together to really try to implement what we know is effective in ivory towers, things that we know that need to get out into the field. I think it's important to reiterate nothing about us without us. So that's another takeaway, is the importance for not just community engaged research, but for community driven research. And that's something that everyone spoke to. It's so hard to do. We aren't really paid. We don't really have funding mechanisms that meaningfully pay to have people. It's daunting to come to a researchers meeting. We often don't set the table for people well, because we don't really want the table settings to be taken away from us. So I think it's really important for us to think about what it means to, meaning we don't want to put ourselves necessarily, it's sometimes threatening to think about doing really meaningful community-driven research, whether it's having hard conversations or thinking about who PI should be, or thinking about where research should happen and the context of research outside of academic institutions. I think you all spoke to those points today. Very quickly, summing up, I think it's important. Another thing, in thinking about cost effectiveness, or thinking about, as Victoria talked about early on, having long-term impact, we sometimes have to focus on intervention targets that are not necessarily in our comfort zone. Economics, poverty alleviation, housing, those are tools that really should be in our intervention toolbox, but aren't things that we as social scientists, epidemiologists, MDs, whatever we're trained as, are trained in. And that's why we collaborate with others. So I think it's important for us in that way to really collaborate to make sure that we have these meaningful interventions that have dual focus. The last thing I'm going to say that I think is so important, that we touched on you all touched on a little bit, in terms of making sure that community partners and people with lived experiences are funded. Funding doesn't really lend itself towards these big, complex, dirty, multi-level interventions that really create meaningful changes. 5-year cycles, like my bread and butter is the NIH, it's really hard to show a change in a grant, getting it off the ground in 5 years, whatever short follow-up time that we have. So I think it's really important for us also to do advocacy work with funders. That's a whole nother type of structural intervention, so that we actually can see the changes that you all propose. Done. Thank you so much.
Yeah, 6 minutes, Susan. Thank you very much. And I like how you ended your comments about advocating for more funding and different type of funding to be able to study these issues and come up with interventions that are unique to the target population we're talking about. And we probably need to work together very soon about moving what we said in the paper to make it real, and talk to funders and others. Really, there is so much work to be done. But thank you for spending only 6 minutes and summarizing so well the meat of the discussion. So we got a question. So as I said earlier, I'm going to use the question that we received prior to the event. And if we have time, we'll go to the chat and get the other questions. But let me start with the first question. And I think, Claudia, I would like you to consider answering it. The question is, I feel cisgender women have deeply failed our sisters. What can we do better to no longer cause harm in the name of helping?
Thanks, Nabila, for the question. And again, I feel like a broken record on this on this panel. But I go back to the principle of nothing about us without us. I mean, I think this is what we can do, what our ethical obligation as cisgender researchers, as healthcare providers, as advocates, as scientists, to do. And the International Reference Group on Transgender People and HIV and AIDS has published guidelines on conducting more inclusive data collection with transgender populations. And we are seeing more research more on HIV among transgender populations. And as that research grows, we need to make space for transgender experts and researchers and scientists, not just as, again, research assistants or, having smaller roles in research, but really in leadership roles. And obviously, we need to disaggregate data on transgender women in existing studies of women and in studies of men who have sex with men. And when we report studies, we need to report and more clearly describe, how we address non-binary populations and whether we've addressed them at all. I think just being able to report and question ourselves as researchers in all of those ways is extremely important. And just to also acknowledge, I think this question really makes me reflect on the fact that on this panel, we could have done better in engaging trans and non-binary colleagues. So, we need to do better.
I fully agree with you. I think we failed not to bring with us as an author and a person with lived experience. So I also acknowledge this limitation. Thank you, Claudia. Let me move to another question we received. How can we advocate for inclusion of pregnant people in research studies? Louisa.
I mean, it's critically important. First, we know that pregnancy increases the risk of experiencing IPV, and we know that it has its own unique, HIV risks and HIV medication things. And I'd love for Jamila to also jump in about the biological mechanisms that could be going on in pregnancy. So we definitely, what happens is we should not have routine exclusion criteria for pregnant women, which often happens because of concerns about that we're somehow going to increase the risk for negative outcomes, pregnancy outcomes. And so I think it's really a matter of being very careful and thinking through what those risks are and strategizing to mitigate those risks and really having, starting with the assumption that you are going to include pregnant women. I also think there needs to be a lot more studies and interventions that focus just on pregnant women as a key population.
I want to ask Jamila and Claudia, because Claudia also written about this issue. Maybe Jamila, do you have more to add to what Louisa and Claudia?
The only thing I'd like to add is that we do know that pregnant people are considered special populations, and so what often happens is because we know that, researchers often don't take the time to go the extra mile and figure out the nuances to be able to include them in research, especially when trying to move through the process of getting the research approved through the institutional review boards at institutions, which can be pretty challenging. And, we as researchers need to be more mindful of the provisions that need to be made, the safety considerations that need to be made, and really clearly outline protocols for dealing with and being inclusive of pregnant people in research.
Thank you. I know, Claudia, you have also written about this issue. Do you have more to add?
Just one point to add to that. Often pregnant people are excluded from research, allegedly because of fear or claim that that the research may cause harm to them or to their babies. But I think we have to recognize that there is potential for more harm being caused if there is a lack of data on what works. And the fact is that service providers need to make decisions about pregnant people, and they're currently doing that with very little data to base those decisions on, and therefore they're not going to be the best decision. So really, we need to ethically include pregnant people in research and interventions, and we need to take the extra time to, as Jamila mentioned earlier, ensure that that's done in an appropriate way.
There is a question about immigrants and persons seeking asylum. What would you say about the research among this population of women?
So I just want to say that this is such an important population. And when looking at immigrants or migrants and asylum seeking individuals, not only does the stress of migration increase the risk of intimate partner violence and HIV acquisition, but forced migrants or women seeking asylum often face even more significant barriers to accessing HIV testing, prevention and harm reduction tools, as well as treatment, just due to mobility or various healthcare accessibility concerns. And so we definitely do need to do more research on this population as well.
I would just like to say, in addition to what Trena mentioned, is that we know we need to think of immigration and forced, exile as, social determinants of health that are driving that relationship between IPV and HIV. And I would also like to say that women who are, we know that immigration and sort of the experience of forced exile increases the risk of IPV too. So we really need to see them as their own key population, but also within all the key populations. This is just another social determinant of health that we really need to focus on.
Another question is, what does the data show about the intersections of racial identity with these other marginalized identities?
What I can say is, and I think I mentioned it earlier, is that we really don't know how the intersectionality of all these identities come together in these key populations. And we definitely know that women who identify as racial ethnic minorities around the world are much more subject to all the social determinants of health, the aggressive policing, all of this, and also the same thing with sexual minorities. So the research has not gotten to the point where we can break it down by all those intersectional identities, both in terms of the intervention research, as well as the sort of epidemiological research linking IPV to different types of HIV. So we're still, I would say, in an infancy stage of really fleshing that out, even though we know the rates of IPV and HIV are much higher amongst certain racial ethnic minority groups and sexual minority groups.
I want to move faster. We have 3 more questions and we have less than 5 minutes. So the next question is, what is the role of women being the minority of drug users on poverty of research, and how can we motivate researchers?
So to answer this question, I just want to say, as we briefly discussed in the paper, that women who use drugs face a multitude of overlapping risk factors that often are related to sex work, incarceration, and IPV, all of which really increase the risk of HIV acquisition. And so to address these unique gendered vulnerabilities, we need a multi-level or a multi-tiered approach that really integrates biomedical, structural, and social prevention efforts. And then I also think one of the other considerations is that men who use drugs, at least in the research, outnumber women who use drugs. And so often the gender-specific needs of women are overlooked or under-researched. And so that can subsequently also lead to inadequate care. And so substance use treatment programs were often traditionally really developed for men. And so they don't consider some of the unique gendered aspects of drug use. And so to effectively engage women who use drugs in care, we need better implementation science research to really help inform how we can integrate service delivery.
And the next question is, what is being done to combat digital violence?
Not enough. I mean, in 2 words. I mean, I really think we don't have great measures of digital violence in all the ways it occurs in different key populations. That is a major starting point. This gold standard conflict tactic scale doesn't include any digital violence items. So I think just to even understand what's happening in all these key populations is a starting point to inform interventions. But I know a lot of DV programs have gotten very savvy about, including digital violence in their safety plans and strategies for making sure that they safely interact with women, knowing that their abusers can often access their digital equipment. So.
Thank you. And the last question is, I'm a doctoral program finishing my research on similar topic. How might I connect with you after the webinar?
I would certainly be happy to connect. I think all of us would be really happy. Congratulations on where you're at.
So thank you, Victoria, Jamila, Louisa, Laura, Claudia, Susan, and Trena for your wonderful, wonderful responses and your really commitment to this research. I truly appreciate it. And really, it has been a pleasure working together on the paper. And thank you. And we have next paper to be thinking about, taking the work to the next level. So thank you for your commitment.
We would be amiss without thanking you as an incredible leader in the field and colleague and friend and mentor. And I know Cathy's spirit is with you today, because I mean, your passion and call for action is just, and thank you for leading us on this.
Oh, thank you, my dear. And I would like to give the floor to the Dean and thank the Dean for her support and all her hard work to help us to put this together. Thank you, Dean Tag.
Well, the pleasure is mine. It's just been a superb session. So thank you, Dr. El-Bassel, for excellent moderating, and to all the scholars on this panel for your insightful and stimulating discussion of research findings and their broader policy implications. I also just have to say, I want to say, I think all of us who've been listening to this are really grateful for showing us the evidence that is available and for pointing to what is missing, both in terms of evidence and in terms of whose voices are at the table or not. And your work, I think, really demonstrates the importance of relevant, ethical, rigorous research conducted via authentic collaborations with community partners. And as you said so well, not just community engaged, but community driven. Best wishes to everyone for participating today, and thanks for joining us.